some research suggests that children who are born after the year 2000 might have an average lifespan of 100. So half of them will live beyond the age of 100. So perhaps some of your grandchildren, for example, might be fortunate enough to live that long. So it really does kind of require that we kind of change our thinking or perspective, and it's a real blessing that people are able to live longer. There's obviously dips and changes that occur. For example, World War II, the COVID-19 pandemic causes momentary changes in this curve, but the overall progress is really is reassuring, and I think it's very encouraging. By 2032, there will actually be more older adults than children in the world, and that's really amazing to think about as well. So let's talk a bit about how sleep is changing as we get older. But first, before we talk about that, it's helpful to talk about what normal sleep is like. So many of us think that when we go to sleep, we just fall asleep and that's it. But it turns out that sleep is a pretty dynamic process. And we actually go through a lot of changes as we're sleeping. So we typically begin awake, of course, and then we will drift down into some of the early stages of sleep, which are referred to as N1, N2, and then N3, which is deep sleep. N3 is deep sleep. And typically what many of us experience is at the beginning of the night is when we'll be having our deep sleep. And that tends to be the case because our body needs to recover and recharge its batteries, and deep sleep is a chance to do that to a certain extent. And then after that, we might move into some REM sleep or some dream sleep. And then we might have a brief awakening, for example. So if you look at this graph, you'll notice there's about 3 to 5 sleep cycles per night. So sleep is not one solid chunk of time, but it's actually 5 brief cycles that occur throughout the night. And that's important to keep in mind because many times we will wake up at the end of one of those cycles. So if you look at this graph here, you might notice that there's a brief wake after sleep onset that occurs around 3:30, for example. And I think that's a really important take-home message from today's discussion as well, which is that it's natural to wake up during the night. And that makes a lot of sense. So probably some of you have had that experience of waking up at night, 2 or 3 or 4 times, needing to go to the bathroom, etc. That's natural. It's a normal part of life. It makes a lot of sense. The human brain evolved 300,000, 400,000 years ago. And back then, we didn't have electricity, of course. And so we had to rely on the fire and other things to help stay warm and safe. If you slept like a log and didn't wake up for 7 or 8 hours, there's a good chance something bad would happen during the night. The fire would go out, the animals would wander away or something like that. And that could be disastrous. So Mother Nature has programmed us to wake up every 2 hours to just briefly check our surroundings and make sure everything is fine. And then we go back into another sleep cycle. Where people have problems is when they stay awake for half an hour or an hour or 2 in the middle of the night. And that's really distressing, of course, to be awake like that. And sometimes that happens because we start thinking about our problems, or we start letting our mind kind of run off with us for the day. And then that can really be unproductive. But the act of waking up, that itself is normal. So I'll just pause for 10 seconds in case anyone has any questions about that so far.
Yeah, so Nalaka, go ahead. Go ahead. I have a question, Nalaka. Can I ask?
Yes, please.
Yeah. At what stage does this cycle of sleeping 3 cycles a night, at what age does it start?
It's actually present throughout our lifetime. So even as young children, we have this. Now, it's a little bit difficult to categorize these stages in neonates and newborn infants because their brain hasn't fully developed, so all their CNS centers have not fully developed. So it's hard to code and classify what stages of sleep they're in. These different stages are classified based upon the pattern of brainwave and eye movement activity that's seen. So there's a certain pattern called spike and wave, or I'm sorry, slow wave sleep that might be seen, for example, or spindles or K complexes. And that's how we can classify sleep into any of these buckets. But in a neonate, they don't yet have the fully evolved brain that we can make these classifications. But broadly speaking, by around age 1 or 2, we can start classifying sleep, and we generally see this pattern, and it continues throughout our lives. The one change, well, actually, there's a couple of changes that occur. So as we get older, there are some important changes that occur. And this is a helpful slide that kind of shows those changes over our life. So that's a great question, Uncle. Thank you for asking that. That's a perfect lead into my next slide. So this is age 5, and this on the bottom axis, and it goes up to age 85. So hopefully many of you will live beyond that into the 90s and maybe even hundreds. And this up here is the minutes of sleep. And this black area here is what's referred to as slow wave sleep, also known as deep sleep. And immediately, one thing that probably strikes you is that we see that there's less slow wave sleep as we get older. And that's kind of a natural process. But you see that the drop really happens a lot until around age 35. And then it stays fairly stable. And there might be another drop again after age 75, where there's a decrease in slow wave sleep. What is slow wave sleep good for? We're not exactly sure, but growth hormone is released during slow wave sleep. And obviously growth hormone is important for kids, but growth hormone is not as good for older adults because growth hormone can also increase cancer growth. So, it's understandable perhaps that the body has more slow wave sleep when we're young and maybe a bit less when we're older. The other important thing on this graph is this line here, which is next to the WASO. WASO is what we call it, and that's just a fancy name for being awake in the middle of the night. And what you see is that people tend to be awake more as we get older, unfortunately. And that's pretty tough. So I'm sure many of you have had experienced that, and I've certainly had times where I've been awake in the middle of the night as well. So this is kind of interesting to think about how sleep changes. Thank goodness, young kids sleep for 10 or 12 hours a day. But as we get older, an important point to remember is that we sleep less, and it's probably natural that we need less sleep as we get older. I'll pause for a few seconds in case anyone has any questions.
I have a question, Nalaka.
Yes, please.
What is the effect of medication, such as sleep-producing medication, on normal sleep architecture?
Yeah, that's a great question. So it turns out that many of the sleep medications, like Zolpidem or Zaloplan or Esopiclone, or which is also called Lunesta, Ativan, etc. Those medicines put people into sleep, but it's actually a lighter sleep. So the sleep that they create is not as restful as natural sleep. So people feel that they're sleeping and they're happy that they're sleeping, but the sleep is not the same quality, and the architecture is somewhat distorted with these medicines. There might be less REM sleep, for example, less slow wave sleep.
I have another question, Nalaka.
Yes, please.
Going back to the slide that you showed first, I see that, the second one, sorry, the second one, as we grow older. The REM, I take it, means rapid eye movements, during which people tend to dream a lot. Does that mean as we grow older, we dream less?
Well, there is a little bit less dreaming. That's true, but that's also a function of the fact that the total sleep time is decreasing as well. So the ball, that gray area looks a bit less, but that's
Yeah.
because the total amount of sleep is also less.
Yeah.
So I think
It-
the absolute percent is about the same.
Right. So I can go ahead dreaming.
Exactly. And
Okay, thank you.
what's interesting when you think about dreams, actually, is that we probably have 2 to 5 dreams a night, but we might only remember 1 or 2 of them. And we tend only to remember the dreams that occurred near the end of the night, just before we wake up to begin the day. So we might have, you might have had a dream at 3 o'clock in the morning, as shown on this graph, and then you woke up briefly, and then you fell back asleep. And it's interesting. There's actually something called retrograde amnesia. So the next time someone tells you you woke up and you did this, and I told you to stop, don't you remember? You can tell them, well, it must have been my retrograde amnesia, and that's why I don't remember it. What happens there is that our brain doesn't have enough time to encode our memories because we're awake for such a short period of time that we fall asleep again quickly, and that's why we forget whatever might have happened like that in the middle of the night. So it's called retrograde amnesia. And when you have a brief awakening that's only 2 or 3 or 4 minutes, it's unlikely that we're going to remember what happened because our brain didn't have a chance to fully turn on and remember the memories. So that's why this dream that occurred right before waking up, you might not remember. This dream here, you might not remember. This dream you might not remember, but then this last dream, then you wake up. That one might be the one that you remember, oddly enough. So that's a great question. Thanks for asking that.
Nalaka,
Yes.
yeah. Now, when you say restful sleep, I believe that's the deep sleep, restful sleep. That's 2 questions. Number one is not during REM. Is that right? It's
Correct.
Yeah. And number 2 is that's defined as what? As when it's a deeper sleep, what are the characteristics of that of associated with? Is it more muscle relaxation, or is it more? What exactly is that?
Yeah, good question. So deep sleep is characterized by a particular waveform that's noted on the EEG, which is called a slow wave. And the brain structure, and are any of you neurologists by any chance on the call?
No.
Oh, okay.
No.
So what happens during regular daytime activity? So hopefully everyone on the call today, if we took a look at your EEGs, if we stuck 20 electrodes to your scalp, we would see that you have a lot of what's referred to as fast activity of low amplitude. That's the characteristic of awake or REM EEG. But then in slow wave sleep, that low amplitude fast activity changes to these very big waves that are very synchronized. So instead of being like a little jiggle like this, it becomes these giant waves that are called slow waves. And the entire brain kind of gets synchronized into this sort of slow wave pattern, for example. And we don't fully understand its role. We don't really know what's happening yet. But that's, some people consider that, more restful. It's hard to know for sure. But N2 sleep is also pretty restful, and N1 or lighter sleep is also quite helpful and healthy for the body. So I don't want you to think that just because you're not getting deep sleep, it's not healthy. Even N1 and N2 sleep are also healthy. Great. So those are great questions. Thanks for asking. Another really important point to keep in mind is that we need less sleep as we get older, and that's another really crucial thing to take home from today's talk. One of the problems I see with some of my older patients is that they are trying to get as much sleep as they had when they were younger, but that's just not natural anymore. So if you are hoping to get 8 hours of sleep like you had when you were in your 20s or 30s, that's just not really possible. And maybe your body only needs 7. So you're going to lie awake in bed for an hour because you just don't need that extra hour like you did when you were younger. This is an interesting research study that shows that point. This is a study which involved bringing people into the hospital for about 7 to 9 nights. and they were allowed to sleep as much as they wanted to. I refer to this as my sleep vacation study. So they were paid to sleep, these volunteers, and they were allowed to sleep for up to 14 hours a day. So what ended up happening is that many people are sleep deprived, unfortunately, especially in our modern society. And so the gray bar represents how much they were sleeping at home. And then they came into the hospital, and everybody slept more the first 1 or 2 nights because they had to catch up from being chronically sleep deprived. But after a couple of days, they reached their equilibrium, and it turned out to be about 7.5 hours for the older adults and almost 9 hours for the younger subjects who are around age 25 to 35. So for any of you with young adult children, maybe you could have an interesting conversation at the dinner table next time where you ask them how they sleep and how many hours they sleep. And hopefully they're getting around 8 hours or 9 hours of sleep. But unfortunately, there's a pretty good chance that many of them are not. I know that when I was a young adult, I was often sleep deprived and pretty exhausted. And helping tell our kids the importance of getting good sleep, like Uncle Maruf was saying earlier, is really valuable because when we get better sleep, we can make better choices during the day, and we actually make healthier eating choices as well. So it turns out that if you're sleep deprived, people tend to eat more food, and they can eat as many as 200 to 300 more calories per day. There was one interesting research study which found that if you sleep deprive people to just 5 or 6 hours a night, they would end up eating almost 500 more calories every day. So at the end of that week of that research study, they actually gained a pound because of sleep deprivation. Because what happens is, because you're sleep deprived, and you probably recall this from your medical training days, for example, et cetera, it's hard to think clearly. It's hard to make the right choices. You're more impulsive, and so you might just grab that candy bar or something like that. So getting enough sleep is a really healthy way to try to help control your weight, for example, as well. It also has a lot of benefits for diabetes and other conditions. So let me pause for a few seconds. Does anyone have any
Nalaka, when you say older adults require 7.4 hours of sleep, what is your definition of older?
Yeah, this was over age 65.
Yeah, but but I've never been sleeping for 7 hours.
Young old adults.
Yeah. Okay. So a person of our vintage requires 7 hours of sleep.
It might be around that. So.
Sorry.
So this is a recommended sleep duration table that was put out by the National Sleep Foundation, and for older adults, they recommend about 7 to 8 hours. But they do mention that life is a bell curve. So some people are on either end of that bell curve. So there are some people who might only need 5 to 6 hours of sleep. And then there are some people who might need up to 9 hours of sleep. But on average, it's around 7 to 8. We're all different, of course. And you can get a sense of how much sleep you need by how tired you feel during the day. And a good way of knowing that is how you're feeling around 10 or 11 o'clock in the morning. It's natural to feel tired at 1 or 2 o'clock in the afternoon, because that's sort of the afternoon siesta that Mother Nature has programmed into our bodies, especially after eating a meal. It's natural to feel sleepy. But if you're feeling sleepy around like 10 or 11, like just a few hours after waking up, that might suggest that you're not getting enough sleep at night, and you might need to spend a little bit more time in bed. Does that make sense, Uncle?
Yes, it does.
Yeah, but everybody is different. So research studies on twins have found that they tend to have fairly similar amounts of sleep need because it's probably genetically programmed. That being said, it's important that we don't deceive ourselves about how much sleep we need. it turns out that many people think that they don't need that much sleep, but then when you put them in front of a TV set, they fall asleep in 5 minutes. So you probably don't need to see a sleep specialist to know that maybe they're kind of deceiving themselves a little bit and sort of saying they only need 4 hours of sleep or 5 hours of sleep, but maybe they really do need 6 or 7 hours of sleep. And if they got 7 hours of sleep, maybe they wouldn't fall in front of the sleep TV set in 5 minutes. But again, it is natural to be sleepy after a meal. And it is natural, obviously, to be sleepy in the evenings. It's just if you're sleepy already in the morning, that's unusual. Great, thanks for asking that question. And then for those of you, like I said, with grandkids or adult children, try to encourage them to get enough sleep. What I tell a lot of my patients is to think about sleep like a step count. So, there's a big push nowadays to get 10,000 steps in and be active, for example. In a similar way, sleep is very important, and it's great that you all are here to learn more about it. And so think about a sleep count, and your sleep count might be 7, for example, because that's 7 hours. And if you're getting 6 hours of sleep, maybe, just like with your step count, you make an extra effort the next day to meet your step count goal because you didn't meet it on Monday. In a similar way, you might want to put aside a little bit more time for sleep the next day if you didn't meet it the prior day. Great. Now, another interesting thing is that older adults actually can handle sleep deprivation fairly well compared to younger adults. So that's another reason why it's really important to encourage our young kids or young adult kids to get enough sleep, because when they don't get enough sleep, they're at higher risk of driving accidents. And that's obviously a horrible thing. This is a research study which used a driving simulator, and the light bar refers to young subjects who were sleep deprived, and you can see that they were having a lot more accidents. So on the left-hand side is the incidents or accidents in the driving simulator, and after about 60 to 90 minutes of driving, you can see that the light gray bar is much higher than the other bars because the young adults didn't handle it very well. Interestingly enough, the older adults handled it quite well, and you can see the solid black bar remains pretty low even after some sleep restriction. So that's kind of an interesting thing to think about. It might be that because older adults need less sleep, they were able to handle the sleep restriction better. So maybe we should have all done our medical training backwards and gone to medical school and residency when we were in our 70s. So that's just a summary of how sleep changes as we get older. And before we move on, I'll just pause in case anyone has any questions.
Nalaka,
yes, please go ahead.
can I ask you a question now? Talking about myself, I have a habit of taking cat naps. You know what I mean? Daytime, 10 minutes, 5 minutes, I am off, completely off, come out. Now, night I sleep, 5 to 6 hours,
Maruf,
maybe the early part, and then light sleep. Is that, if you take multiple nap, that habit of sleeping in the daytime, does it have a negative effect or a positive effect on night sleep?
Yeah, that's a good question. And
Maruf, put the screen on. Put the whole screen on.
Pardon?
Yeah.
Okay.
The screen is on. This is on.
Yeah.
Sorry, yeah.
So basically, one thing I often tell my patients is that sleep is like a gas tank of your car. So imagine if you need 7 hours of sleep, that's like having a gas tank that can hold 7 gallons of gas. So if you stop at the gas station and you put in 2 gallons of gas, and then you drive down the street and then you go to the next gas station, you can't put in more than 5 gallons of gas because there's already 2 gallons in there. So in a similar way, if you get a lot of sleep during the day, you might need less sleep at night because you've already filled up your gas tank a little bit during the day with sleep, so to speak. Now, short cat naps are probably okay. And interestingly enough, yeah, it's true that taking a nap is actually pretty healthy. And it turns out that, you know, taking an afternoon nap, for example, many people do better cognitively after they've taken an afternoon nap. So some research studies that were done that involved having the subjects take naps found that their neurocognitive test performance improved after taking a nap in the afternoon. You know, they were kind of filling up their tank, so to speak, and their brain was able to function a bit better in the afternoon after a nap. The key question is, how are you sleeping at night? And if you're able to sleep at night okay, and you're not having too much trouble with your sleep at night, then it's probably okay to be taking, you know, afternoon naps. So I think that for some of my patients, I'm fine if they take a half an hour or an hour and a half nap, but I advise them to maybe they need less sleep that night because they've already filled up their gas tank a little bit with sleep. That's one thing. Now you mentioned that you're taking short cat naps of 5 or 10 minutes, and it's unclear how helpful those are, because in a short cat nap or 5 or 10 minutes, you typically don't go into any deep sleep, for example, but you are still getting some sleep. So maybe it's helpful for you. One thing that I worry about is if people are taking involuntary naps. That is, are they falling asleep when they don't want to fall asleep? And if that's the case, then you probably are not getting enough sleep at night. Obviously, you know, we don't want to be falling asleep while we're driving. We don't want to be falling asleep while we're talking to somebody. That's a sign that maybe we're sleep deprived. And I think that's a big problem in our society. We're really sleep deprived. Let me pause. Any other questions or comments?
I have a question.
Please.
You know, does it matter what time you go to sleep?
Yeah,
good
question. Yeah, good question. So, so it turns out that as we get older, our sleep patterns can change quite a bit. So, another fun fact from today's talk is that we all have an internal alarm clock. So you have an alarm clock on your smartphone, and you also have an alarm clock in your brain, it turns out, as well. And that alarm clock in your brain is a cluster of about 500 neurons, and that's what causes you to wake up more or less at the same time every day. So you probably had that experience where you went on vacation and you wanted to sleep in, but you still woke up at 6 o'clock in the morning, and it was very annoying. That's because the internal alarm clock in your brain went off. The problem with that alarm clock is that it's genetically programmed to a certain extent, and everybody's is a little bit different. So some people that clock wants them to wake up at 6, and some people it's at 8 o'clock, and some people it's at 9 o'clock, and some people it's at 4 o'clock in the morning. So, you know, there are the night owls, and then the morning larks, you know, people who like to get up early, for example. As we get older, sometimes this changes. So especially when we retire. So you might have, you know, had a job and you had to get up at like 5 in the morning to get to work and so on and so forth. But as you get older, that's no longer an issue, and you can kind of do whatever you want with your sleep. And that, unfortunately, can often make your sleep worse because your brain gets confused. So one thing that I often recommend to my patients is to try to stick to a regular schedule with their sleep, and then the alarm clock in your brain knows what to do and when to help you sleep and when to wake you up, because your brain has been watching what you've been doing. So I would just encourage you to try to have somewhat of a regular schedule, as opposed to just, you know, getting up at 6 one morning and getting up at 11 the next morning and getting up at 7 the next morning. Getting up at a regular time in the morning is really helping for the most part. Any other questions?
Yes, sir. I wanted to ask, can you hear me?
Yes, go ahead.
Yeah, is there a physiological basis for sleepwalking, and can you be held responsible for anything that you did or could do when you are sleepwalking?
Interesting, yeah. So there's a couple of different things that can occur while we're sleeping. One is sleep talking. where you might, say things during your sleep, and you might be talking from your dreams, for example. Tends to occur more in children, as many of us know. There's sleepwalking, which also is somewhat related to sleep talking, and it might occur as we're transitioning from one stage of sleep to another. And then there's another problem, which is called Rem Behavior Disorder, RBD. And that is when we act out our dreams. So sometimes my patients tell me that they were being attacked and they had to fight back the attacker, and that's what happened in their dream, and then that's what they did in the bedroom. They started fighting with an imaginary attacker, for example, and that is a very dangerous situation to be in, because you're not, your eyes are closed, you don't know what's happening around you, and you're like fighting, and you might hit the wall, you might fall out of the bed or something like that. So it is possible for something like that to occur, and if you or somebody is having these situations where they're doing complicated behaviors, so just talking and just walking, that isn't such a big deal, but like trying to fight somebody or trying to choke somebody or something like that, that's a bit more serious, and that might be Rem behavior disorder, and you should definitely talk to your doctor. And then a sleep study is really helpful there to find out whether there's any abnormality of REM sleep. And then if there is, there's some medications that can be used. It can be dangerous for the patient and their bed partner. In regards to being held legally responsible, probably what would happen is that there would be an evaluation by a physician. And then if that found that there was REM behavior disorder, that would probably be like a justification for reducing any legal penalties, I'm imagining.
Thank you.
Yeah.
Nalaka?
Yes, go ahead.
Yeah, I got two questions. When I sleep in the nights, I'm getting personal questions. I can sleep maximum 2-3 hours. Sometimes when I'm very good, it might go 4 hours. After that, I'm wide awake. Then I force myself to sleep, and because I think I must sleep for at least 6 hours. I always sleep in the afternoon. I feel sleepy and I sleep, and that's a habit that has gone on for years. So now that sleep pattern, when you say is not healthy, because I may not be getting the 6 or 7 hours for the whole night, even cumulatively with the nap. Two questions. Number one, is that abnormal or is that normal? Do I get normal for myself or is that, So I think, if it is abnormal, what are the deleterious effects?
Sure, no problem. I think it's okay to take a nap in the afternoon if you feel better from it. Now that you're retired, you can definitely squeeze that in, and that's okay. But the important thing is, like that gas tank analogy, you might just need less sleep at night because you're getting some in the afternoon. So, let's just do the math, for example. Let's say you slept for 2 hours in the afternoon from like 1 to 3 o'clock. Then at night, you don't need 7 hours of sleep anymore because you've already gotten 2 hours of sleep. So you only need 5 hours of sleep that night. Now, let's say you go to bed at midnight and you plan to wake up at 7 o'clock in the morning. That seems normal, right? Midnight to 7 o'clock, that's 7 hours. That seems normal. But the problem is you don't need 7 hours because you've already gotten 2 in the afternoon. So you only need 5 hours of sleep that night. So you probably should go to bed at 1 or 2 a.m. and get up at 7 a.m. or go to bed at 12 and get up at 5 or 6 a.m. because you don't need to spend 7 hours in bed. If you try to spend 7 hours in bed, I guarantee that you're going to be awake for 2 hours because you only need to get 5 hours of sleep that night. You don't need 7 hours in bed. So that's a problem that some of my patients experience, where because they're filling up their gas tank a little bit during the day with a nap, they don't need to put as much gas in at night, and they can spend less time in bed at night. And that's helpful because, again, if you're spending 7 hours in bed and you only need 5 hours of sleep, you're going to be awake for 2 hours. And then you're going to think then that's kind of miserable, being awake in bed for 2 hours with nothing to do. You can decide what you want to do, Uncle, Do you want to keep taking the naps? That's okay. Or do you want to get rid of the naps and then you'll maybe sleep a bit more at night? Whatever you want to do is fine. It's your life, and you should, at this age, you certainly have the right to do what you want to do. And so, you could, if you want to take that 2-hour nap, then you might just need an hour or an hour and a half less in bed at night.
So, but my question is, if I wake up at night, say at 3 o'clock in the morning, or I usually go to bed about 12:31, and if I wake up at 3 o'clock or 4 o'clock, should I wake up or should I force myself to try and go back to sleep?
Sure, that's a good question.
Right.
So, yeah, it definitely, you definitely want to get, 4 to 5 hours of sleep, at night, on average. And if you're getting up at 3, there's another 2 hours that hopefully you'll be able to get. And by adjusting how much time you spend in bed, your body will learn to naturally fall asleep at 3 o'clock again. Your body is keeping you awake because you're supposed to be awake for an hour or two, because you don't need 7 hours in bed. So your body has kind of learned over the years that it's okay to be awake at 3 o'clock in the morning, because your brain knows you're going to be taking that nap in the afternoon. So you basically just need to kind of do the math and adjust how much time you spend in bed, either with the nap plus sleeping at night, and then just adjust the amount of time you spend in bed so that it matches how much you're sleeping. So if you're awake for about an hour at 3 o'clock in the morning, maybe you need to go to bed half an hour or an hour later at night, or wake up half an hour or an hour earlier in the morning. The important thing to understand is that you need to pick a pattern and you need to stick with it for at least 2 weeks, because that's how much time it takes to reprogram the alarm clock in your brain, right? We don't have a rewind button and a fast forward button that we can press. Instead, our brain is watching what we do and then resets itself based on what we're doing. So once you figure out what times you want to sleep, try it for 2 weeks. You might be tired at the beginning because you're not used to it, but eventually your brain will figure out what's going on, and then you'll have less insomnia at night. Does that make sense, Uncle?
Yes, it does. And yeah, it does. One last question. What is the relationship between nocturia, frequency, and sleep? Does the poor sleep cause that, or does nocturia cause poor sleep?
Yeah, that's a good question, and especially for a lot of the men on the call. Prostate problems become more and more of a problem as we get older, and that can interfere with our bladder function, of course. So it's hard to know which came first, the chicken or the egg. It's hard to know whether we're just waking up because of the 3 to 5 sleep cycles that we naturally have from that slide I showed you. And maybe when we wake up, we just happen to notice our bladder's full, so we go to the bathroom. That's one possibility. The other possibility is that our bladder gets full and then that wakes us up. So we don't know which came first, the chicken or the egg, for many people. I think that one clue is how you urinate during the day. Are you having trouble with frequent urination during the day? And if you are, maybe the bladder problems are causing the night problem. But if you're able to urinate okay during the day, then maybe it's just the natural sleep process, and you just happen to notice your bladder's full. Generally speaking, if this is a problem, it's helpful to drink less liquids right before you go to bed, because obviously the more liquids you drink, the more you need to clear from your system over the next couple of hours. So everybody's case is a bit different. And that's kind of a nice segue into my next section, which is about sleep apnea, actually. Before I do that, though, let me ask if there's any other questions.
Yeah, no, look,
Can I ask you something? Sorry,
Benita, I want to ask a quick question. But before that, I want to say how glad I am that I tuned in. It's 1 o'clock in the morning here in New Zealand, and I can listen to you for hours on end. And I'm not feeling sleepy at all. That means you're such a good talker.
Oh, that's nice of you to say. Thank you.
You thanked me for bringing you forward.
Thanks, Benita. No, the question is, can we change our body's requirements for the number of hours of sleep that we require? Can we train our body to manage with less sleep?
Yeah, that's an interesting question, and that brings up a couple of important points. First, the more active we are, naturally, the more sleep we're going to need. So on average, if you exercise for about an hour, you might need about 30 to 45 minutes more sleep that night. So one way to help get more sleep at night is to try to be more physically active. So I often encourage my patients to be more physically active. Tai Chi, yoga, walking, those are all wonderful things to do. And you'll get more sleep at night. And that makes sense, of course, right? Because the more active you are, the more rest you need to recover from that. So that's one thing. And it might be that, if you're running around all day, if you take the kids or the grandkids to like an amusement park or something or whatever, and you're running around after them all day, you'll be more tired and you'll need an hour more of sleep that night, for example. But if you're, sitting in front of the computer all day or watching Netflix, you might need less sleep, that night. In regards to changing how much sleep we need, I don't think we really have the answer to that yet, unfortunately, because everybody's different. And then also, as you know, our medical conditions change. We might develop thyroid problems. We might have, blood pressure problems. We might be given a new medication like a beta blocker. Beta blockers really interfere with sleep a lot, unfortunately, because they throw off the alarm clock in the brain a bit. So all of these medicines can have an effect too. I think we don't know the answer to your question, unfortunately, about whether we can change how much sleep we need.
Just one other point I want to ask you. I feel guilty if I sleep too long because we are coming to the end of our lives. And if you sleep for 1/3 of the remainder of your life, I feel that's a bit of a waste of time.
Interesting.
So,
yeah.
I try to keep awake more. I suppose that's bad for my health, and that will eventually shorten my lifespan.
Yeah. I would probably think that it's better to try to get the rest, and that if you don't get enough sleep, it does have negative effects. And the way I think about it is there's two things that are happening. First of all, there's research to show that the risk of diabetes can be higher, for example, if we don't get enough sleep. In addition, there are other conditions. There's some people who believe that not getting enough sleep can increase the risk of cancer, for example. People who do a lot of night shift work, like sleep technologists or nurses who do night shifts, unfortunately have higher rates of breast cancer, for example. So I don't want to scare anybody. I'm not saying that not getting enough sleep leads to cancer, but there's a possible link there that we don't fully know yet. But so there's that kind of long-term health risk. But in addition to that, our brains don't function as well if we don't get enough sleep. So it's great to have an extra hour in the day because you're cutting off an hour of sleep. But that extra hour is not going to be a quality hour because your brain is not going to be working at peak effectiveness. So, your ability to, talk to your friends, your ability to write that diary or that memoir or whatever, it's all going to be compromised because your brain is not working at peak efficiency because you're trying to squeeze in that extra hour. So you're kind of robbing Peter to pay Paul, so to speak.
Yep.
And that's why it's better to try to make sure you're giving yourself the time you need for sleep.
Thank you.
Yeah, you're welcome. Great questions. Any other questions?
Yes.
Nalaka, sorry, go ahead.
No, it's carry on, Karun, I can ask later.
Yeah, Benita asked about cat naps. I have, from my medical school days, almost trained myself to sleep for 15 minutes, 10 minutes in between. And frankly, I get up very refreshed even now. Even now, before a long drive, I might go and sleep for 15 minutes and wake up and feel refreshed. And I don't know whether it's psychological or physiological or what, but is there a downside to that? I do it as a habit.
Yeah, I think that's fine. That's fine, actually. And we often recommend that to our patients, especially before a long drive. If they are having trouble with feeling sleepy, it's much better to take a 15-minute nap and then get in the car than trying to take a 15-minute nap while you're driving the car. That's not a good choice. So please take the nap before you get in the car. That's perfectly fine. And if it works for you, that's fine. But just add up how much you're sleeping and then subtract that from how much time you spend in bed that night so that you can match up how much time you spend in bed with how much sleep you need. And then that will help avoid being awake in bed for an hour or two because you took like 3 or 4 cat naps during the day.
Yes.
That's one strategy to consider.
Thank you. Yeah.
Okay. Thanks, Nalaka. It's just a clarification. Could you tell us something about this, what the patients complain about the restless leg syndrome during the night? And what's the role of meditation in helping you to sleep well?
Sure. Those are good questions. So, an unfortunate condition is called restless leg syndrome. It's something that I have every once in a while. It's basically a feeling where you have to move your legs, typically in the evenings. It might occur when you're traveling on an airplane. I tend to have the worst restless legs when I'm on an airplane flight for some reason, and it's just this feeling that you've got to move your leg every minute or two. And if you don't, your legs feel really uncomfortable. And so that can interfere with sleep a lot. And it might be related to low iron levels. So if you're having that symptom, ask your doctor to check a ferritin level. And if the ferritin is low, maybe you need some iron replacement therapy. And there's actually a variety of medications that are quite helpful for taking care of restless leg syndrome. And I'd recommend that you would consider, talking with your doctor because they might be able to recommend some of those and improve some of the symptoms. And then you had another question. What was your other question, please?
On meditation, how does that help? They tell you to meditate to get a good night's sleep.
Yeah. So
what is the association there?
Yeah, I think that generally makes sense. And the reason that it's helpful is because part of the reason why we tend to stay awake at night is because our mind is racing away with worries and thoughts. And I'm sure those of you with kids and grandkids, you have a lot of things to think about. That's you never stop being a parent, and you never stop worrying about your kids. So you can always think about that, and then at 3 o'clock in the morning, your mind just might start wandering off and thinking about these stressful thoughts. And that's where meditation can be helpful, because meditation is basically teaching yourself to control your mind. So meditation is teaching yourself how to redirect your mind. And what we do is we practice during the day when we meditate. So if you meditate for 15 or 20 minutes, your mind is going to wander off 50 or 100 times during that, and you teach yourself each time to redirect your mind and bring your mind back to the focus of the meditation, whether it be breathing or something like that. And so it's like you're training a puppy, and each time the puppy is learning that when you say sit, the puppy will sit, like that with your mind. And when you tell your mind stop, your mind will stop worrying. And if you develop that skill during the day, you can use it at night. When you start having worrisome thoughts, you can direct your mind back to something relaxing. And what I recommend that you think about at night, for example, what's really helpful for a lot of people is a gratitude practice, or like a loving kindness type of meditation. I think many of you have many things to be grateful for in your lives. You've done really well with your careers. You've lived to this age, and you probably have had really full and enjoyable lives. Many of you have really been grateful to have been able to find new homes in new countries. These are all things that we can be grateful for. And that's a much healthier thing to think about at night than worrying about problems. So Another helpful thing to remember from today's talk is that if you are awake at night, to consider a gratitude practice where you're reflecting on the things you're grateful for. And that's healthy in a couple of ways. One is it helps to reduce your sympathetic stress system and helps to increase your parasympathetic relaxation system, and then you'll naturally fall asleep. So that's the first benefit. You'll fall asleep faster. The second benefit is that it's a little bit like, working with a computer. Many of you type something on the computer and then you close the lid and you go get a cup of coffee or something, and then you open the lid of your computer. What's the first thing on your computer? What you were typing, what you were working on. So in a similar way, if you go to sleep with gratitude in your mind, you will wake up with gratitude in your heart. And that way you will feel better about your life. So that's why a gratitude practice is a helpful thing to do at night. If you are awake and have a few minutes to think about things, rather than worrying about whether your son has paid his bills for the month or daughter has done something or whatever. So it's better to think about what we're grateful for example. Does that answer your question?
Yes, thank you. What about alcohol in the night?
I think you know the answer to that. You don't need me to tell you anything. Alcohol makes our sleep worse. So we might be able to fall asleep faster at the beginning, but alcohol makes us more likely to wake up 2 hours later. I actually just spoke with a patient recently who was drinking a pint of vodka every night to fall asleep. That's not a healthy choice. And now he's on Valium to try to get off the vodka. So I guess from one V to the other V. So alcohol is not a good choice. And I think drinking alcohol, maybe a glass of wine around dinner, is probably not the end of the world. But I really wouldn't drink alcohol too much after dinner. Great. I wanted to briefly mention sleep apnea. And then Uncle Maruf, I don't know how much time you had scheduled for today's talk, but feel free to interrupt me at any point.
Go ahead. Yeah. Nalaka, everyone is absorbed, so go ahead.
Everybody is
enjoying
awake.
it.
Well, if you want to
Everybody
take,
is awake.
if you want to take a
fallen
short nap,
asleep yet.
go ahead.
Everybody's awake.
Right, so,
You're not putting anybody to sleep. So that's a good thing.
That's good. All right.
So, Nalaka,
I should have let
I hope
continue, and then we will have a better flow of
participants. It should come on the screen.
Sure. I'm sorry.
one question.
Tony, you had a question? Yeah, go ahead.
Yes, in addition to sleep apnea, would you also talk about the utility of this sleep hygiene that people talk about? Does it help or does it not help?
Yeah. So sleep hygiene helps a lot, and I'll just take a moment to talk about that before we go on to talk about sleep apnea. Sleep hygiene basically means having good habits when you go to sleep, and I think we all kind of know what these are. It's just hard to follow them. The good habits include things like waking up at a regular time each morning. That's one of the main things to think about. So if you wake up at 7 o'clock one morning and you wake up at 11 o'clock the next morning, that's not good because the alarm clock in our brain gets confused. So trying to have a regular wake up time. I tell my patients that they can break that rule once a week. So once a week you can sleep in, but the other 6 days, try to stick with that regular wake up time. One important thing is don't sleep in if you had a bad night of sleep. So if you had a bad night sleeping on Monday night, don't turn off the alarm clock on Tuesday morning so you can sleep in to catch up, because that's going to confuse your brain. So, just like an athlete has to stick to a schedule, you have to stick with a schedule as well in order to optimize your sleep. So that's one thing, trying to, maybe once a week you can sleep in, but the other 6 days, try to have a regular schedule. And then the other healthy thing is to set a time when you're going to stop watching Netflix or stop using the computer. So if you want to go to bed at midnight, maybe 11 o'clock is when you will always turn off your Netflix or always turn off your computer. Netflix and YouTube, their job is to catch you. Their job is they're doing everything they can to grab you and suck you in so that you don't turn them off, right? So their job is to find ways to get your attention so you will stay up till 1 or 2 o'clock in the morning watching Netflix or YouTube. So you need to, beat them at their game and stop at 11 o'clock or 10 o'clock or whatever, and not let yourself get sucked in. So, because obviously if you go to bed at 1 or 2 o'clock because you were watching something on Netflix and you get up at 7, that's only 5 hours of sleep and you're going to be tired. So it's really hard to fight back against these giant companies because they're very good at manipulating us. But it's important to turn off, Netflix or YouTube. And then another thing that's helpful, is to turn off the smartphone. And there's a do not disturb mode in the smartphone. So I'd encourage you to consider using that as well. And then lastly, to try to build in like a healthy schedule for when you go to bed. If you want to do a little bit of relaxing yoga, if you want to do some minor things around the house, like water some of the plants or something like that, or maybe if you have like a journal or a diary that you're keeping for your kids or your grandkids, you could write something in that. But having like a nice relaxing sleep, pre-sleep ritual that doesn't involve Netflix or YouTube or HBO is a good thing to do. Maybe there's a book that you'd like to read. Maybe there's a religious book that you are looking at or something like that. And you can read that a little bit as well. So having a nice ritual, it makes a big difference as well. And those are all important parts of sleep hygiene. Does that answer your question, Nicole?
Yes, it does. Thank you.
Great,
Thank you.
Great. All right. So I'd like to make sure we have a little bit of time to talk about sleep apnea because that's a pretty important problem and it's often under-recognized in older adults. Many of you might be aware of sleep apnea. Some of you might have sleep apnea. Basically, sleep apnea is abnormal breathing at night. And this picture here shows what's happening. And some of you with a radiology background might be familiar with this from head and neck CT scans. But this is the tongue, and the back here is the oropharynx. And as we breathe, air has to go through this small space. So I often tell my patients that our windpipe is about the size of a pen. It's not that big. It's rather small. So what happens when we go to sleep is that this can close off at night. So here's a fun fact that you can tell your grandkids or your kids. It turns out that our tongue muscle, and many of you perhaps are aware of this, our tongue muscle attaches to the front of our jaw. So our tongue attaches right here at our jaw. So when we stick our tongue out, our tongue looks like it's getting bigger, but our tongue muscle is actually contracting. So the next time you see the grandkids, you can have everybody stick their tongue out at the dinner table, and then you can tell them that their tongue muscle is contracting when it comes out. And that's the same thing that, for example, frogs can, stick their tongue out and catch a fly or something because the tongue is attached to the front of the mandible and shoots out when it contracts. Now, when we go to sleep, our tongue relaxes. And when our tongue relaxes, you can imagine it's going to go back. And now it's going to close off the windpipe. And that's what happens in sleep apnea. So the tongue is closing off the windpipe for the most part, and that's what's causing sleep apnea. Now, sleep apnea is a big problem. And this video, which might work, we'll see, is a video which shows somebody who has sleep apnea. And you can see the patient is snoring. Hopefully you can hear them snoring. And you can see they're kind of gasping a little bit. And right about there, at that point, they stop breathing. So their tongue has gone back and has closed off their windpipe. Now, you can see they're trying to breathe. Do you see the two belts on their chest and abdomen? See how they're going up and down? So they're trying to breathe, but they can't breathe because their tongue is closed off their windpipe. Let's see how long this lasts. There we go. So that was about 45 seconds that they weren't breathing. Now they're gasping for breath. And then let's see what happens next. It happens again. And let's see how long this lasts.
Injuries and deaths. That to me is a component. It's something that really should be a never event. And yet it is something that is sadly.
There we go. That was his first breath. So for all that time, he wasn't breathing. So, you know, you don't need a medical degree to know that that's not healthy. And that can increase the risk of stroke or heart attacks, unfortunately. So, you know, sleep apnea is a serious problem, and not everybody has a case that's that bad, of course. You saw that patient was obese, for example, but many people have sleep apnea. And if you woke up that gentleman and said, you know, you stopped breathing for 2 minutes, he would say, what are you talking about? I was sleeping, everything was fine. He wouldn't believe you, but anybody watching him would know that doesn't look healthy. So that's sleep apnea. And there's a chance that, you know, some of you might have it. There's a chance that I'll get it as I get older, for example, etc. And it's present in about 1/4 to 1/5 of older adults. This graph here shows the prevalence of sleep apnea. It's present in about 1 in 20 young adults, and it's present in about 1 in 4 to 1 in 5 older adults. So it does become more common as we get older, unfortunately. It's possibly due to the fact that our muscles get a bit more lax as we get older, and that can increase the risk of sleep apnea. One problem is that we often don't know that we have it because we're sleeping, of course. And as we get older, many times couples sleep in separate bedrooms, or they might lose their partner and they might be sleeping alone, etc. So there's no way to know. One simple way to find out is to, when you go to visit friends or family, the next morning you can ask them, by the way, did I snore? And if they say that you were snoring, maybe you have sleep apnea. There's also a lot of apps that you can get on the smartphone, and there's one called Snore Lab, SNORE Lab, and that can record your snoring at night and can tell you whether you might be at risk for sleep apnea. And then if you have sleep apnea, then you might want to get evaluated by a sleep doctor, for example. And the reason this is important is because obviously not breathing at night is not good for your heart or for your brain. And really what a lot of us are concerned about is dementia, right? None of us want to get dementia. And the issue here is that poor sleep might possibly increase the risk of dementia. And that kind of makes sense a little bit, because when you sleep, you're recharging your brain. And if you're chronically sleep deprived, and et cetera, or if you have sleep apnea, you're not getting good sleep. And that lack of good sleep might increase the risk of getting dementia later on. We don't know for sure, but there is a concern that could be the case. Now, we treat sleep apnea in a variety of ways. And this particular research study asked the question, if you treat sleep apnea, can you delay dementia? And what they found, possibly, is that especially in the early stages of dementia, what's referred to as mild cognitive impairment, or MCI, in the early stages of dementia, treating sleep apnea might be able to delay the development of actual dementia. But once we get actual dementia, it's probably too late, and treating sleep apnea is probably not that helpful. So that's why being aware of this is an important thing, and considering an evaluation can be helpful if you have a problem with snoring. It's also helpful to consider getting evaluated for sleep apnea if you're going in for any kind of surgery or operation. This is an interesting research study looking at 106 older adults who were having knee surgery, and it found that people who had undiagnosed sleep apnea were more likely to develop delirium in the hospital. So your risk of having delirium and complications from the surgery might be increased if you have undiagnosed sleep apnea. And that's why possibly getting it treated or evaluated before you go in for a knee surgery or a hip surgery or something like that might be worthwhile. Now, it's important to keep in mind that symptoms are a helpful clue. So either having a lot of insomnia at night and waking up a lot during the night, or being really tired during the day, those can be symptoms, especially if it's connected to snoring that was found on one of those apps that I mentioned. And if you have both of those, then you might want to talk with your doctor about getting an evaluation, because if you have the symptoms and you have sleep apnea, it does have a negative effect on mortality. And we see that patients who have symptoms and have snoring, they had a higher risk of passing away. These patients are shown on the lower line here. And then people who didn't have sleep apnea or didn't have any symptoms, they had a better survival, shown up here on the higher line. So that's why it's worthwhile getting looked at. Now, one thing to mention about sleep apnea is how we can treat sleep apnea. And what I want to just mention there is that there's a couple of choices that can be done to help treat sleep apnea. Many of you are aware of CPAP, which is that special mask that you wear. And understandably, we're all reluctant to do something like that. But the masks have gotten much, much better over the past 5 years, and they're really quite small now, actually. So it's much more comfortable. And if you do have sleep apnea and if you do get it treated, you might actually find that your sleep is deeper and more restful, and you might actually need less sleep. That gets back to an earlier question about do we need less sleep as we get older? It might be that if you can improve the quality of your sleep, you might need less sleep. And if you have sleep apnea, treating it would improve the quality. Other options to treat sleep apnea include a special mouthpiece that's made by the dentist that helps to open up your windpipe. So if you don't like the CPAP, you could consider that. Sometimes sleeping on your side can help improve sleep apnea. And there are actually special backpacks you can buy on Amazon. For example, you can just type in backpack and sleep apnea, and you can see them. And then you basically wear these when you go to bed, and they help you to stay on your side when you go to sleep, so you don't roll over onto your back. The other option is surgery, and there's a new surgery called Inspire, which is also hypoglossal nerve stimulation, that can help with sleep apnea too. So there's a variety of options to treat sleep apnea if one has it. So let me pause for 10 seconds to ask if anyone has any questions about sleep apnea.
Yeah, Nalaka, is that overdiagnosed?
That's a good question. I think it depends upon what symptoms a patient has. So if a patient has trouble with feeling sleepy during the day and is falling asleep while they're driving their car or something like that, and then they have sleep apnea, then that certainly is not an overdiagnosis. And I've seen that many of these patients get better when you treat their sleep apnea with CPAP. So in general, it's usually underdiagnosed. It's not recognized fully. Mild cases of sleep apnea, where the apnea-hypopnea index is 5 to 15, like a milder case, we have a little bit more wiggle room about whether to treat that, for example. But if it's moderate or severe, most likely you might want to get it treated to help reduce the risk of cognitive impairments later on in life.
Nalaka, I just want to know whether low sodium can be detected in people who have these daytime sleeping and sleep apnea. And the other thing I want to know, the value of melatonin and its effects on
Yeah. Okay. So in regards to sodium, I don't think we have a clear answer about how sodium is linked to sleep problems, etc. One possibility is that it might be related to congestive heart failure. As many of you know, when people have significant congestive heart failure, they often have hyponatremia or low sodium levels. And people with severe congestive heart failure also often have severe sleep apnea. Sleep apnea is often linked with heart failure. And we don't know, again, which came first, the chicken or the egg. Did the sleep apnea cause them to have multiple small heart attacks while they were sleeping, which led them to have heart failure, for example? We don't know. Or is the heart failure causing the sleep apnea? We don't know. But nonetheless, heart failure causes a low sodium, and that causes sleep apnea, and that could be a reason. But we don't have a clear answer, and I think it's too early to say if there's a link between sodium and sleep apnea. And then in regards to melatonin, that's an interesting question. Melatonin can be quite helpful for sleep. Melatonin levels tend to get less as we get older, so it can be useful to consider trying melatonin if you're having trouble with insomnia. Melatonin is quite safe. It can interact with some medications, so you might want to just double check with that before you take melatonin. Just talk to your doctor and they can do a quick check to see if melatonin interacts with one of the other medicines you're taking. And then the other thing with melatonin is that it's good to try to take the lowest dose that works for you. You might start off with like a 3 or 5 milligram dose, but I would encourage you to try to lower it down to a 1 milligram dose or a 0.5 milligram dose if that can work for you. Lastly, if you're going to take melatonin, try to take melatonin that's pure melatonin. Try not to take melatonin that has a lot of other things mixed into it. Many of the companies that make melatonin, in order to differentiate their brand, will include things like rose hips, chamomile, valerian, other compounds. And probably that's okay, but we don't know for sure. And it could be that some of these other things that are mixed in with the melatonin tablet might be having an interaction with your medicines or cause side effects. So that's why, generally speaking, pure melatonin is often the best option. Melatonin can be helpful for people who are having trouble timing their sleep, but it's a little bit tricky to work out all the details, and it's often good to talk to a sleep specialist to figure out the right time to take melatonin. But you can take melatonin half an hour before bedtime, and it might help you. But if it isn't doing the trick, you might want to talk to a sleep doctor to figure out the best time. Some people take melatonin 4 hours before they go to bed, for example, and it can be helpful in certain cases. Does that answer your question, Uncle Mario?
Can I add a question to that, Doctor? Given melatonin's short half-life, you favor delayed release melatonin, the drug in Britain is Circadin, and what are your views on melatonin receptor antagonists, such as agomelatine?
Yeah, those are great questions. So
didn't answer get the questions. What was the question?
Sure. So the first question was about sustained or continuous release melatonin, and the second question was about the proprietary melatonin agonist, like agomelatine, for example. Sustained release melatonin can be helpful in some cases, and I think it's reasonable to experiment with different versions to see what works for a given person. And then in regards to the melatonin receptor agonist, they're reasonable choices as well. They tend to be more focused on the melatonin receptors that are related to sleep, and they might have a stronger effect. So if you can afford them, they're a little bit expensive. They can be a couple of dollars a pill, whereas melatonin, at least in America, is available over the counter, and it's $5 for a bottle of 50 pills. So at least in America, it's available like that inexpensively. So in many other countries of the world, it's available as Circadin, which is I think a 2 milligram continuous release, and it's a reasonable choice to try if you'd like to see if it helps you.
So,
Go ahead.
Padmalingam, go ahead.
Yeah, it's an excellent presentation so far. My question is, at what age will you suggest that most of us are past 80, a sleep study for older people? At what age? Or there are people who have lost their partner, so there may not be a complaint of snoring, or there is already you are stopping sleeping for half a minute, 1 minute, 2 minutes. So what is your recommendation about a sleep study for older folks like us? For example, I am still living, and so far my wife has not complained, except she does say that I snore.
Sure. Yeah. So I think that some of the important symptoms of sleep apnea are feeling very tired during the day or having a lot of insomnia at night. Those are two key symptoms. And if you're having those symptoms, and you are having snoring, then it can be worth getting a sleep study, and that would avoid overdiagnosis problems. So the symptoms are an important indicator that it might be worth evaluating. Now, other conditions where sleep apnea is common include congestive heart failure. So if you have congestive heart failure, you might want to get a sleep study as well. And treating the sleep apnea can be beneficial for these patients as well. One other condition where sleep apnea is common is stroke. So if you've had a mini stroke, for example, you might want to consider talking to your neurologist about getting a sleep study, because there's a small chance that treating sleep apnea might help to reduce the risk of another stroke, for example, and nobody wants to have another stroke. So those are conditions where you might be more inclined to pursue a sleep study. There's different kinds of sleep studies. There's what's called a home sleep study, and there's what's called an in-lab sleep study. The home sleep study, of course, is done at home. It's quite convenient, and it's less accurate, but it's very convenient, especially during this pandemic time. So you could discuss with your doctor about doing a home study, and then they'll give the kit to you. You put on a belt around your waist, and you put a little probe on your finger, and you go to sleep in your bed. It's very easy to do, and that can help give an answer as to whether you have sleep apnea. And then, like I said, you could try using one of those apps like the SnoreLab app in order to see whether you might be at high risk of sleep apnea. But on that night, you might want to sleep in a separate bedroom, because you don't want it to pick up your wife's sleep apnea, and then you're the one who has to go to all that trouble.
Thank you. And one more thing, most of the people with hypertension need a sleep study. Am I right or wrong? Hypertension?
Yeah, that's true. Sometimes hypertension can be linked to sleep apnea as well. And typically speaking, we do sleep studies in patients who have difficult to control hypertension. So if you're just taking, Norvasc or amlodipine or losartan, and your blood pressure is controlled, that's fine, not a big deal. But if you're taking 4 medications and your doctor's talking about adding clonidine to control your blood pressure, you might have a really severe case of hypertension, and maybe then you might need a sleep study, again, to avoid this issue of overdiagnosis. So those are conditions where you might consider a sleep study. And I don't think that you're too old to have a sleep study. So I think that we all want to try to avoid the risk of getting dementia or having a heart attack. And I think if you're able to join this Zoom call, you're doing pretty well cognitively, and you ought to do everything you can to keep your brain active and healthy.
Thank you.
So Nalaka, your explanation for the obstructive sleep apnea is mechanical, right? Therefore, you say to improve sleep and the perception of having had a good sleep in the morning, does taking melatonin or losing weight or something like that, would that help instead of a CPAP? Because CPAP is a very uncomfortable thing. I mean, I've been diagnosed CPAP for a long time, but putting it on and doing it is a different story.
Yeah, no, that's true. I certainly understand, and about half of my patients have a hard time using the CPAP therapy. although interestingly, we're doing a research study with older adults who have mild cognitive impairment, and 75% of them are using the CPAP on a nightly basis. So we've been able to have good success with that. I think they're just worried about getting dementia, so that's why they're using the machine more regularly. I think that other options include the oral appliance that's custom made by a dentist, like I mentioned. And then there's also the hypoglossal nerve stimulation, the Inspire procedure. That's another option. And then positional therapy, sleeping on your side, can often improve sleep apnea as well. Now, in regards to weight loss, that's a little bit tricky because as we get older, it's hard on our bodies if we lose too much weight, because we can develop osteoporosis. That is, we can lose bone in our back, for example, and then we can also develop sarcopenia, which is we can lose muscle mass. And these are unhealthy consequences of excessive weight loss. So typically, if a patient is morbidly obese, then I recommend that they lose weight. But most people who are morbidly obese don't survive into their 80s, unfortunately. And so many of my patients are a little bit overweight, and typically I don't really recommend too much weight loss if someone is overweight. Only if they're really obese would I recommend weight loss if they're older. Great. So any other questions?
Nalaka, laser surgeries for which part of, is it the tongue, or where do you use the laser for?
Yeah, that's done. If we were to go back to that picture of what causes sleep apnea, we would probably let me just see if I can
The
find,
posterior part of the tongue.
yeah, exactly. Let me just see if I can find that picture really easily. Here we go. Okay, so the laser surgery is often going to remove the uvula, which is that, what hangs down behind the tongue.
Hanging out, yes.
So that's often removed in laser surgery, and sometimes that can help with the problem. Sometimes the surgery procedures might involve fixing the nasal septum. If there's a deviated nasal septum, that might make sleep apnea worse, for example. And then in the more severe cases, it might involve removing part of the back of the tongue to open up the windpipe. But that's a pretty big operation, and I typically don't recommend that operation for my older adult patients. I would probably recommend the Inspire or the hypoglossal nerve surgery before that big tongue operation.
So by stimulating the hypoglossal nerve, what does it do?
It stimulates the tongue, so the tongue muscle doesn't relax.
Muscle. It's actually supplies the muscle, tongue. Yeah.
Yeah, and so the tongue muscle doesn't relax, and then the tongue muscle can stay tight, and the tongue muscle will not fall back and close off the windpipe. That's how the hypoglossal nerve stimulation works. So it turns out that the average age of our patients getting hypoglossal nerve surgery at Penn is around 60, 65. So I was surprised to learn that. So we have a lot of older adults, or I'll say young older adults, getting the surgery. And so far it's been going reasonably well. It's a little bit expensive, unfortunately, and I don't know if it's covered by your insurance or available where you are in the world right now. But typically we recommend starting off with CPAP, because that is very safe and has no side effects. And if you can get used to it, then it's effective. My patients who have trouble with CPAP, I typically recommend that they try different masks, because there's a variety of different masks that are available, and they're getting more and more comfortable. So sometimes that can help solve the problem. But if that doesn't work, then either an oral appliance or surgery could be an option if you want to consider. Or like I said, sometimes sleeping on your side can be helpful. Any other questions?
Yeah, Nalaka, one question. So you find no role for medications like zolpidem or one of the many cocktails of medications that are available, including melatonin. I'm not still sure what the indication for it is. So you are saying that it degrades sleep, and so what is the role for it? I mean, it's used so prevalently all over. And when patients ask me, I say, try some medications, various medications. Yeah. So.
Yeah, that's a good question. So there's three broad categories of medications for insomnia. There's the benzodiazepine or Z drug medications like Zolpidem or Ativan or Valium, and those are generally not a good choice, and because they can become addictive. Sometimes they're okay if you need it just for a week or 2 or 3 weeks, but I try to avoid using it for longer than 1 month. If a patient needs one of these benzodiazepine or Z drug medications for more than a month, what I typically do is something called intermittent dosing, where the patient is only given 10 or 15 tablets for the entire month. And that way the patient can choose what nights they want to use it. But because they're not taking it every night, they're less likely to get addicted to it, right? Because if you're taking it every night, then you've now become addicted to it, unfortunately. So that's how I might use those drugs, but I try to use them rarely. Then the other category of drugs would be something like doxepin or trazodone, which are not benzodiazepines and are not addictive. And these are probably the best choice. So if you are going to treat a patient for insomnia, I recommend starting with doxepin or trazodone as your first choice. But they don't work for some patients. And again, I think it's best to use them like, maybe 10 or 20 nights out of the month and not every single night. But some people need to use those every night. And if they need to use those every night, those are a safer choice than the benzodiazepine drugs. And then the third category is melatonin, and that can help some patients, and things like agromelatonin can be helpful for some patients as well. And that helps about 1/3 of my patients. Everybody's different. Some people who have long-standing insomnia, they've had insomnia for years and years and years, and it doesn't respond to medications, it might be sleep apnea that's causing the insomnia. And, understandably, taking a medication like Ambien or Zolpidem is not going to help the sleep apnea. It often makes it worse, actually, the Zolpidem, because it relaxes the muscles a bit more, for example. So that's kind of a quick answer to your question about the medications. But it's reasonable to start with melatonin because it's a very safe medication, and it's available. It's relatively inexpensive in most cases, and then it's reasonable to move on to something like doxepin or trazodone, and then maybe move on to Zolpidem if it's still not working, but to use it rarely. Great.
What is the indication? I mean, when you say insomnia, these people just can't go to sleep, is it?
Correct. So insomnia is a clinical complaint. So if a patient complains that they can't go to sleep, they have insomnia. Now, one thing that's useful is these smartwatches. So I recommend, if you're wondering about your sleep, that you consider getting a smartwatch. And the brand that I recommend is the Fitbit. And I recommend that you get the Charge 4. The Charge 4, that's the latest one. That's one of the better ones for looking at sleep. There's a less expensive one called the Inspire, I think. It's not as good for sleep. So I'd recommend the Charge 4. And then that'll tell you a lot about your sleep. And then you can see how much time you're spending in bed, how much sleep you're getting, etc. They're remarkably accurate. One thing I want to just warn you about is they're oversensitive. So they're going to show that you wake up 10 or 20 or 30 times a night. Don't worry about that. They're oversensitive, and they're going to show you wake up a lot. They also give you something called the sleep score. I don't know what that means, and I wouldn't pay too much attention to that. I would instead really be focusing on what time you go to bed, when you wake up, and how many hours of sleep you have. Those are the most useful metrics. I'm afraid I have to go at about 10 o'clock. I'm sorry about that. But are there any other questions that I can help answer? This has been a great talk. You all have asked some great questions.
Can I ask a follow-on question on the drugs? What's your experience of the new class of orexin 2 blockers?
Yeah, those are interesting drugs. Suvorexant is one class, Belsomra, for example. And these drugs, can help some patients. I typically avoid using new drugs in my patients because new means that they haven't been really tested well in the general population. So I like to wait a year or 2 or 3 just to see if any safety alerts pop up as it's being used in the broader population. So I haven't been using Belsomra very much or Suvorexant very much. I think it can help sleep a little bit. And for some patients, it's worth a try. It can be a bit expensive, unfortunately, as well.
Thank you very much, Nalaka. I mean, it's you number of questions. We still have more questions if you stay on. Yeah. So I hope we have not abused your kindness.
No, not at all. Not at all. It's been great. It's been great talking with all of you. I think you've asked some great questions.
Yeah, it is really wonderful.
Yeah.
Thank you very much, Nalaga. That was interesting.
But anyone else wants to, but I want to really thank you, because this is a concern to lots of people, and it's been a concern to me, and so on. But so it's wonderful. We really do appreciate it. I'm sure I'm speaking on behalf of everyone. If you had stayed for 1 more hour, we could have still talked, but it's been very clear and extremely useful, and thank you deeply from our hearts.
Thank you very much. Thank you.
Well, it's been an honor talking with you, and it's great to see so many of you on the call and being alive and healthy and being active like this. And these kind of meetings are really good to stimulate your mind and get you thinking about things and live a healthy life and be engaged. So I wish you many more years of happiness and health in the future.
Thank you.
Thank you. Take care. Bye-bye. Have a good
we can stay on. We can stay on.
Thank
He's
you.
a busy man. We are not busy, so we can stay on. Yeah.
Bye-bye. It's nice talking to you.
Bye.
Thank you.
Bye.
Bye-bye.
Bye.
Yeah, hold on. Shall we? Few more minutes. Shall we? People have to go, or?
Yeah, few more minutes.
Yeah.
Okay.
Can you take the screen off, Maruf?
Yes, I am.
Yeah. Okay. That is Saro. Thank you very much, Saro and Nihal. That was really useful. I mean, this is a very timely topic.
We should have a follow-up on this. I think he had a full cycle of things, but because of the way we were getting excited about it, and it was a very
we were very interactive. And I think hi Dharma Alagaratnam is.
Thank
hey,
you.
how are
Thank you for organizing it, Karunian. I'm been diagnosed with severe sleep apnea, but still kicking.
I mean, I think if you do a test, all of us will have diagnosed. I've always thought a little cynically about it. But
they tested me and found me negative.
Oh, okay.
So
Hey, Milroy, welcome, Milroy. I thought you were.
Milroy came.
Dharma, I don't know whether you all know Dr. Alagaratnam. He's a Chicagoan, close to Saro's house.
Yes.
And he was actually my intern at Lady Ridgeway Hospital. So he was 2 years behind me, right? Behind us.
Say it again.
You were 2 years after us, right?
Graduated in '69.
Yeah, 3 years.
Yeah, do the math.
2 years.
So we can so you can join us if you want. We have a talk. And yeah, so anyway, so folks, thank you very much for coming. I'm it's great talk and really nice talk. Helpful.
Yeah.
This hello. What's happening? Hello.
Okay.
Yeah, we can hear you.
What is the next plan? Can we have a quick talk about what you want to do? Yeah. I disappeared. I don't know where I went. Okay. Hello.
Right here.
I can't see myself. Okay, 1 minute. Okay.
We can see.
We can see
We can see you. Yeah.
You
are filling the screen.
Yeah. Let me get out. I do so many. I'm a biology teacher for my grandchildren nowadays with the pandemic. So I'm Zoom.
So, Karunian, you said we are going to talk about heart disease in Asians. You're going to lead that, aren't you?
Yes. Now there is a video that will tell more than what I can say. But certainly that's very timely and topical, especially for our children, more than for us. So we can do that, and I'll get some stuff out. And there are some books that I'm doing. I've been sort of having a focus on that issue, partly because it's a personal problem for my family, and then that's more practical. But there is also, if anyone is interested in knowing to the most conceptual part of it, there is the metabolic syndrome, which we all have, which I've spent studying, but I think there's a little more theoretical and boring. But I think we'll do the hard disease, and I'll pick out a video and show the video. The one that I recommend, which is about 6 years old from Stanford, is about 1 hour long. I think we can look at that or parts of it and do it. So we'll certainly do that. Yeah. So that's the next topic.
Arunian, it will be on the 29th of May.
Yeah.
Take a note.
Yeah.
And, today's attendance was a little bit better than before. We went up to 30. And I think I also suggest that we have at some time convenient for Nalaka, he should come back because he had a big circle of information. But because it was a didactic one, we went completely out of control on time. We had done about 2 hours of meeting, and that was good. And interestingly, it is on the YouTube. If you want to review, anyone if you want to watch it, you can. I'll send you the address is on the brochure that I sent you, and I also have recorded it. If any one of you want it downloaded in. Recorded.
No, I think we went out of time because it was free and easy, and I like this format. It's a better format than one-way listening. So I don't know what others think.
I think this is the best of all the discussions we have had, because of the fact that we had a free didactic, and it was a participation of all of us into the lecture, and we gained a lot. And you will see it by just watching the YouTube video, and it will be very interesting. Right. I think the next meeting will be on 29th, and Karunian, you'll be in charge of giving me an agenda.
Okay. All right. Yeah. We certainly, I'll certainly work on that. But after that, any other subjects? Milroy has a lot of subjects on people appropriate for people of our age. Milroy, you want to do a talk?
I can add on to coronary artery disease, definitely.
Which one?
The coronary
artery disease. Okay. Okay. All right. Yeah.
Anytime you want a filler, anytime you want a filler, I have life care products that are coming into existence, and also the thing about negative ion, the values of, and lot of things about that are developing in the region of life care. And if you put out life care, it is end of life care, although we are almost at the end of life care area. But I think we can have anything that you all want. You can send it to me by email or something, and I can pick up any of those subjects. There are interesting subjects in that area. So I think we start with the heart management of taking care of the heart as a first one, and then we go on by system by system.
Just a question. What do the people think about this format, having pretty serious discussions and lectures? Should it be every 12 meetings, or can someone do a little magic and some lighter stuff going forward? Because once we were criticized for having too heavy stuff. Any thoughts on that?
Maybe have a mix of both. Have a mix of both.
Okay.
I think that's a
didactic and this format.
I think it is called edutainment, education, and entertainment.
Okay.
See, since you found it interesting, it went on for 2 hours. If you have the next one which is not interesting, you may want to cancel it. So you might as well match and mix.
Okay. Yeah.
Karunian,
okay. Yes.
Patmalingam here. I think the format so far, in my judgment, has been excellent. And I think we will continue the way it is. And about sleep medicine and sleep apnea, the British guys had been saying something about singing lessons to improve sleep. Did you all hear, Narada? Do you know about singing lessons to improve sleep?
No, I
think the
wife sings or somebody else sings.
Nona mata gamata yanda ona.
No, but I think on a personal note, for me, not having stress and getting into the sleep hygiene has been the best treatment that you can do. I mean, it's so different when you with the COVID, I stopped working and not running a medical group, and immediately my sleep improved. So I think anything relaxing, whether it's sleeping or Nalaka talked about what is positive thinking, or he used the word gratitude thinking. I think it's just wonderful therapy, relaxation.
Quite is well.
First time I heard that, yeah.
Very
but
familiar.
another thing that certainly helps is meditation. Certainly meditation helps a lot of people with sleeping.
Most of our dreams come during the REM sleep.
But most people I know are using medications. I don't know. I mean, Nalaka is against it, but
thank goodness I have never used, and I sleep good for 5 to 6 hours, and I'm happy.
Anyway, any other Lawrence, you got any magic up your sleeve?
Well, I can do one trick. I can just do one trick. Just
Which one? Sorry, what's that?
I can do one magic trick a week. Every time we can do something. Yeah.
I think that's wonderful. Okay.
Yeah.
So after the heart meeting, you can have a magic show. One.
Just one trick, not a magic show.
So Lawrence, any interesting subjects you can teach us? How to prevent dementia?
In relation to Narada's question as to what's the point in getting old, what's the meaning of life? So I thought we were going to do it this week, so I've already sent it in to her tomorrow. So we can do a quick one on reasons for living and reasons for dying, since that's a prospect all of us are facing.
We can have one on anti-aging as well.
Yeah.
You're muted.
So do you want to have one of those very subjective philosophical discussions on why should we live?
Yeah.
Yeah, we have to get a philosopher.
What about euthanasia?
Anyone knows a good philosopher?
I think if you all give gratitude therapy that Nalaka suggested, we'll all want to live. But anyway, so do you want to have
count
that?
Our blessings. Count our blessings.
So do you want to have that before or after the heart disease story?
So heart disease first.
Okay, all right.
Heart disease first. You've got to be alive first before we find a reason to live.
Okay, so but my heart disease story, if you want, I can give a little brief introduction. It's going to be a video, essentially.
Okay.
It is going to be from the start. Stanford has recognized that South Asians have a special predilection, and they have started a center, and they are studying, and they're collecting data and also treating. So it will be essentially about that, but there is some talks that are really, really good from them, and I'll put one of those as the talk for the next time. Yeah.
If there's an interaction, we ask you.
Yes, I will have some. I have looked at it, so I have some understanding of it. I also would recommend, if you want, there's a book called South Asian Heart Health. So South Asian Health Solution, specifically directed towards that, which I would recommend all the younger folks, our next generation, people like Nalaka should read, which essentially focuses on the issue of risks and mitigation of risks through lifestyle. The author is a fellow called Rohan Singha, S-I-N-H-A. I can put it on the web. I would recommend reading. It's geared towards the lay people, but it goes through all the metabolic and other parameters that are risk factors and how to manage that. It's called South Asian Heart Solution by Rohan Singha, S-I-N-H-A. He's a physician in Palo Alto area in California. And the South Asian Arts Institute is coordinating all over the world, and they have a lot of new data coming up anyway.
My voice is... Hello?
Hello?
Hi.
Yeah, hello?
Yes?
Yeah, go ahead.
Karunian?
Yeah.
Can you hear me, Karunian?
Yes, I can.
You know who this is?
No.
I can't identify them.
Rabi, who?
Jayasri Fernando. Remember?
Yeah, Jayasri. Sorry, Jayasri. I do appreciate
I couldn't place it.
As soon as I got up, I got came here, so I'm not wearing it.
I couldn't quite. I couldn't. I am having dementia.
I can also see. I'm seeing Mohan. Is that Mohanlal there?
Yeah.
Mohanlal,
put up your hand, please. For
all friends and all Moroto boys.
Yeah. Jayasri, sorry, I didn't recognize you, Jayasri.
That's all right. You're all right.
I
came in late, and it's wonderful. Nalaka was a little kid. We've seen him grow up, and so wonderful to hear him.
Nalaka, Jayasri, do join us next time too.
Yes, I will do that.
Jayasri, you are living fairly close to where I was, wasn't it, in Moratuwa?
My guy, I was living down YMCA, that path, you know.
Yes.
Yeah, you all are living that way, and I was living at Idam.
Were you not one of the family of all giants, all tall, huh?
Tall guys, all the people. And also, I used to play badminton with you. You were so good, because I couldn't play with you. But
Actually, can I have your mobile number? Or
sure. It's 217.
Okay.
994.
Yes.
4751.
All right.
So, Jayasri, where are you now?
I'm in South Central Illinois, about 200 miles south of Chicago.
Yeah.
So we have been here a long time now, because Dharma is a very close friend of mine, Nihal, Saro. Of course, I haven't seen Mohanlal for 50 years.
We should try and have one meeting, special meeting, just to get all our batchmates together. Perera and Abesari Gunawardena, we'd love to have them. Just tell them that.
Karunian, wasn't there a suggestion that to have a batch reunion on the Zoom? That's to call.
Yes, in June.
Sure, great. So, Maru, what is the date for that? Let's do that.
June. I'm going to send you all one year calendar starting from May 2021 to April 2020. And I will include some of the things I suggested, like any one of you, if you will kindly communicate with me and tell what subject you like to speak on, I'll put additional subjects and then we can mix and match. And myself and Karunian and any other person wants to join in and participate in the arrangement of this time, the so-called activities, it'll be good. And I can...
But Maruf, there was a suggestion to have a pure reunion, and we can have a Zoom reunion, and we can have some singing and dancing or something. I don't know, there are ways of doing that. So can we do that in the month of June?
Month of June we can. I will arrange a studio.
But you'll have to give enough notice and persuade people to come.
I'll get some singers
if you want. Not June, July, put it on one of those.
Okay. We will do that. We'll do that.
That book you mentioned.
Can someone get out of the Sri Lankan fellows to come in?
Sorry.
Difficulties. We'll try.
Yeah, well, we'll if it is a reunion, I think we can persuade. So that's why please do your best to get everyone in and call it a reunion. And we're going to have
Sri Lankan ones. You may have to ask Ranjit to try and organize the whole lot to come in.
Where's Ranjit? Ranjit was here. Ranjit is here still, or Ranjit?
Ranjit sits on.
Ranjit gets good sleep, and so he didn't stay on.
Sri Lankan, they can.
Ranjit is very relaxed, huh?
Ranjit is accessible, but Ranjit is on the quieter side. Listen.
What's that?
What I will what I suggest is July is better than June for the reason that June is too short. Organize a bigger group, so we'll try all our effort to get people together, and I'll send you the names that I have, and those who have the mobile numbers, enter it, and anybody who wants to put in a subject, I would like to talk about. And yes,
can we have a new team to just organize that reunion? Someone with creative ideas, maybe Shanti and Mohanlal and Narada, or someone organize huh?
What about having it for 2 days, like, divide it so that you have some programs that are running for
2 days,
2 hours, 2 days, or one suggestion, not consecutive days or 2 days, this one, so that they will meet up for something that should continue. Because you won't be able to finish it in within 2 hours, would you?
So Maruf, can I suggest a new committee just for the July meeting?
Sure. What do you mean?
So I would suggest, who are the volunteers?
Excuse me.
Keep Maruf and yourself there, then the others can join.
No, I would suggest someone else with, we have two.
And from UK, I think we can appoint Shanti or Glory.
Okay, Maruf, take it down by then. Shanti, Benita, you are one.
No, I am here in Vicky is there. No, Vicky will do a better job.
Okay, all right. But Benita, you got connections in Sri Lanka also, Benita. I think.
Ask who? Here, there, nobody here.
Hafsa, take notes, please. Hafsa is here. She'll take notes. Don't worry.
Yeah, but at least get people in.
Okay, so have one person in charge to organize, and who will be the volunteer who would take to organize?
Why not, Karunian? Why not ask Mary to organize it? Give them something to organize so they will come in. See, requesting them to participate is not going to work.
Yes. So we will have 3 people.
You might as well tell them, look, you are Mary and somebody to be an organizer, bring from them.
So Benita, I suggest that you be the organizer, chief. Okay.
No, I can ask, but I will from there.
You were. So I said she's probably joined. Yeah.
And there, Saro is there. Ask Saro.
Okay, all right. Okay.
Saro, what about getting hold of Mary to come in?
Okay. All right. Any other discussions?
Just a quick note. I had sent that book you mentioned, Karunian, to everybody as a PDF file. The Southeast Asian Solution, that book, that should be arriving in your email.
So it is available on the web as a PDF file?
Don't ask how I sent it. So
I got it on Kindle and hard copies. I give it to everyone I can know. All our next generation have to, the people who have to know.
Now you've got it as a PDF.
Are you sitting on the group, is it, Lawrence?
I sent it off your email. Yeah.
Email.
It's already done.
Good, excellent.
Great.
So Maruf and Karunian, both of you head the committee and we'll be the subcommittees to help out.
No, we are part of it.
Okay, we'll see. We are all part of it. Yeah. Thanks, Lawrence. How did you get a PDF file? It's free of charge?
Very good.
These are things you don't want to know in life.
Because I pay $20 to Amazon every time I want to gift it to someone.
Well, now you can get it for free. And if you want the Kindle version, I can get that.
Can I come to you for other books too that I want?
Yes. If anybody wants books, movies, films, documentaries, just email me.
Yeah, okay. Good.
Wow. Okay, that's wonderful.
Okay,
folks.
Maruf, thanks very much
Bobby,
for
how are you,
taking
Bobby?
the time. Thank you. Thank you very, very
Thank
much
you.
for taking the
Thank
time.
you.
Thank
Thanks
you.
a lot.
Saro,
Okay.
thank you very much. Thank Nalaka from the bottom of our hearts. It was a very good
Yeah,
talk.
yeah,
We are very
Enjoyed it
proud
very
of
much. Thank
We're
you.
proud of him, and also we have inherited him as our nephew already.
Well, yeah, not only Saro, but to Nihal too.
Yeah.
Thank you, Nihal and Saro. Yeah, it was a wonderful talk. Yeah, very nice.
Yeah. Thanks everyone, and nice seeing you all.
Thank you. Thanks very much.
Dharma, you are
Bye-bye.
most welcome to Dharma. You are most welcome to join this group.
Yes, yes, I will.
Yeah.
Learned a
And
lot.
for those who don't know, Dr. Alagratam is a radiologist in Chicago, and he was my intern.
Dharma, you give me your number if you don't mind. I will add you to the group. Yeah.
Sure. 630
630
988
988
7285.
7285. Okay.
Great. And Jayasri, please join us.
Yes, I will join you.
Jayasri, you will be in the group, and we can interact through
I
the
will.
group.
Yeah,
All
I
right.
mean, so some of the seniors, I don't know some of the seniors, but Karunian was a very close friend long ago.
Another
Yes, I know.
I want to make to all of you, those of you can join Signal as a group, then we can have a larger number, and Signal is one of the best of the chat groups that you have.
Right.
All right, there is Signal and Telegram, but Signal is much better, and I'll send it to you on the WhatsApp. So look through that. So if you join there, because once you reach 256, we will stop on this group, and we'll have to form another group, and it's a lot of confusion.
No, but for the moment, let's continue with this, Maru.
Yeah, thank you. That's very nice. Very, very nice.
I'm not changing, but I'm saying just I'll send you join on Signal. We'll keep on the sideline. Yeah. Okay.
Okay, great. And yeah, thank you. And if it helps Banda, we can have another 5 o'clock meeting. Because now that I know he's, I'll get up early and then sleep again. Nalaka
So
says
what I
that.
want to know is, by changing the time, did we put anybody out of step?
Hello?
I asked Maru to change the time.
Well, Milroy, Vijay has not joined, but Milroy joined. So it's only Vijay. There are 3 or 4 others in California, but did Leonagi come? He was not here. And then Nicetas Fernando never joins. There are a couple of guys, Nicetas, Cones. These guys don't join.
I got to thank Nihal and Saro for inviting me.
Benita, the worst we could become on the American side is 5 a.m. So your side, it's very nice. I think in the middle, everybody is nice. So I think
Yeah, because you see, 5 a.m. is not so bad. Even if you give it to us, then 3 a.m. Banda coming at 3 a.m. is.
Yeah. No, Banda was really nice. So you can put a couple of 5 a.m.s. Now that we know how to go to sleep. Yeah, I'll go and sleep get up and sleep late.
You get sleep.
You're having a time nap, so you can cut off your sleep at 5 o'clock. Don't worry.
Okay.
I told you what happened. Yes.
All right, folks.
All right.
Thank you very much. Thank you.
California, muchas gracias.
Bye, Glory.
Bye.
Bye, Benita.
Bye-bye.
Good night.
Thank you, Saro, again. Thank you.
Thank you, everybody. Thank you.
Thank you.
Bye.
Thank you. Thank you, Bobby. Take care, Bobby.
Mohanlal, bye.
Thank you.
Bye. Bye.
Bye.
Mohanlal.
Milroy, thank you. See you.
Bobby.
Mohanlal. This is Milroy, Triani's cousin.
All right.
Yeah.
Ya estoy desconectando.
Okay.
Alicia.
Thank you, Professor.
Sam Suisa and Nalin didn't come this time. So.
Sam didn't come here. That's good. I'll get Sam.
Okay. All right. Take care.
Thanks, everybody.
Okay. Bye.
Thank you.
Bye, Beta.
Bye.
Len and Hafsa, please remain. Brief sum up. Hi, Koda. All right?
Bye.
Okay, bye.
Hi, Dr. Maharuf. I'm here.
Yeah, I know that. I don't think Dr. Salima is there. Salima,
Yeah,
you heard your answer for your melatonin?
yeah.
Okay. Padman has left.
No,
Hey.
no, I'm here. I'm here. Hi. Hi, Maru.
Hi.
I didn't know that you all were starting 1 hour early.
Yes, 1 hour early. We announced it on the. You should have looked at the brochure I sent.
I see. I think I'm a little lazy on technology. Hi, Bobby. How are you?
I'm fine. How are you?
Fine. You look sharp,
meeting.
man.
You're going to another meeting today?
I tried to call you. You didn't answer. That's why.
Actually, I have my annual meeting on the other computer. My Zoom meeting with the Academy of Family Physicians of Delaware.
Delaware. Okay.
Yeah.
No. But I called you yesterday.
Somehow I think I was too busy yesterday. Anyway, you look sharp, Maru. This is a great thing. I think his presentation today was superb, actually.
Oh, yes, excellent.
We
very good.
keep our knowledge more sharp, I think, with these meetings, in my judgment.
Very valuable.
You are doing a fantastic job, Maru.
Good. This is all life
I've
care.
done this 20 years ago.
We can do for another 20 years. Don't worry.
But one more comment is, you have so much of involvement all over. I don't know how you do it. I think your CV is like this. How do you do it?
Yeah, the more you can do, the more you can get to do.
You are also a professor in New York. You are a professor in New York. You are a professor in England. You are a professor in Saudi Arabia. How about Sri Lanka? Why don't they make you a professor emeritus in Sri Lanka?
And Malaysia.
I was in Malaysia before. Hello?
Bobby. So how is your health, Bobby? You okay?
Not quite. I had a recent fall and have some stitches here on my forehead.
I think you called. When I tried to call back, it did not take my call several times.
I'm having balance problems.
Be careful, be careful.
Hmm.
I think it looks like you may have to have your companion in New Jersey with you, I think. That's my suggestion.
I'm going to switch off close the YouTube, all right?